That was a phenomenal tour de force, Peter. We look forward to questions from the audience and everybody else. We're now going to hear from the president of the AFS, who's going to talk about the sphincter and the crura in health and disease. John Lipham is professor of surgery at the University of Southern California. He's already been introduced to you, and I'm not going to take away his microphone time anymore. John?
All right, again, thank you. And I also wanted to thank Felice and everybody that organized this. Felice put in a tremendous amount of work putting together this agenda, along with Blair Jobe, Reg Bell, and Submeet. So this is one of the most powerful agendas I think I've ever seen in my career, and it couldn't have happened without Felice. So on that note, disclosures. I'm going to take a little bit of a different angle with all of this today. A little bit of a different story. And so really, first and foremost, I want to wish everybody a happy St. Patrick's Day weekend. Doesn't get enough attention. The Irish military would also like to thank you. What I'm going to do is I'm going to give you a little bit of a history lesson. A history lesson that's mixed with math and physics, which admittedly sounds a little bit like death by PowerPoint. But stay with me for a little bit, because I will argue that you can learn a lot from history, a tremendous amount from history. And so I'm not only going to focus on the GERD barrier function, but I'm going to focus on the other half of the story. At the very end, I'll talk a little bit about the Achilles heel, because all this has to matter in some way, what I'm about to tell you. And so for 20 plus years, I have sat through conferences like this, time and time again, and I will tell you that the world revolved around the lower esophageal sphincter. For God's sakes, I've heard more about the lower esophageal sphincter than any human being should. And it just keeps going. It's about the LES deterioration, these TLESR thingamabobs where there's neuromodulation something leading to reflux, the LES shortening, TLES shortenings, abdominal length, thoracic length, some sort of length-pressure relationship. It's all about the LES. I will tell you, in 20 plus years, nobody mentioned a damn thing about anything else. It was all about the LES. So I started to think. That's always dangerous. I fully admit it, but I started to think, and I said to myself, because I was alone, because I have no friends, I said, I'm like, why? Why do 80% of people or more have a hiatal hernia that have reflux? Is reflux causing a hiatal hernia? No. Is it coincidence? Maybe the hernias are unrelated. Nobody talks about them. It's like the redheaded stepchild. So I did the unthinkable. And don't do this. I started to read the literature. And this is where it gets dangerous. So here's where the brief history lesson starts. And it all really started with a guy by the name of Allison, who was a thoracic surgeon. And Phil sort of dove into this area, and he was convinced that the barrier to reflux was analogous to the anorectal junction. In fact, the crura of the diaphragm were analogous to the puborectalis. And these are pictures from his original drawing, and you can see that the crura do kind of look a little bit like the puborectalis. Now, unlike Peter, he didn't really think there was much of an intrinsic lower esophageal sphincter, because there really was no thickening of muscle in that area to claim to be a lower esophageal sphincter. And the way he would do his repairs was quite interesting. He'd go into the chest, he'd then make a hole in the diaphragm, he'd stick his hand through that hole in the diaphragm to get into the belly, he'd pull the hernia down, and then he'd sew up the crura. He'd then also sew up the hole in the diaphragm, but that was his repair. And it wasn't bad. He reported on his first 33 patients, it was about 50% successful in stopping reflux. Not a bad procedure. About 5 years later, Nissen comes out with his idea on what's causing reflux. And for Nissen, it all focused on the lower esophageal sphincter. And this is his original publication here, where he describes his gastroplication, wrapping the stomach around the end of the esophagus. Two cases, neither of which involved a hiatal hernia repair. In fact, he didn't think the hiatal hernia repairs were important. And he didn't think they were important because he thought the plication itself would prevent herniation. In fact, that's what I was taught. You needed the bulk of the Nissen to prevent it from the stomach from screaming up into the chest. If you didn't do a Nissen, the stomach was for sure going to land up in the chest. And so this debate raged on, and probably still rages on today. In fact, I guarantee it rages on today between Nissen and Allison, whether it's all about the LES or whether it's all about the hiatal hernia repair. Well, in an effort to end this debate in 1971, a guy by the name of Woodward out of Florida decided to look at this. Who was right? He thought maybe both were right or both were wrong. And so what he did was a series of patients, 127 of them, where he just fixed the hernia. Didn't do anything else. Then he did 103 where he only did a Nissen. Didn't fix the hiatal hernias, because again, they weren't important. Early days of pH testing, you know what he found? That if you only did one or the other, 50% of the patients still had reflux. It gets to this idea that there's actually two components to the barrier. It's not just the LES, it's this two-sphincter hypothesis. This is a publication from Brian Louie, who's sitting here in the front row, who did an interesting study where he did high-resolution manometry intraoperatively as he was fixing these hiatal hernias and doing a Nissen fundoplication, and he did it at various stages to sort of tease out the contribution to length and pressure that we see on manometry. And what he found was actually quite interesting. Part of that increased length comes from the hiatal hernia repair. Indeed, part of it comes from the Nissen itself. But what was really shocking was when he looked at pressure. The vast majority of that increased pressure that you saw in manometry actually came from the crura repair, not the Nissen fundoplication. And so here's where it gets a little complicated. So try to stay awake, stay with me here. But in preparation for this meeting, I subscribed, cost me $40, I subscribed to something called the Journal of Biomechanical Engineering. It's a journal that exists, I swear to you. $40. These guys took on this very topic. What constitutes the barrier to reflux? And so this isn't a group of doctors, this is a group of engineers. Group of engineers looking at what constitutes that barrier to reflux. And so they put together their biomechanical model of all of this. And they used some very high-definition cross-sectional imaging, similar to what Ravi uses. They then used something called the governing equations of deformation elasticity. I have absolutely no idea what that means, but it sounded really important. Then, in addition to that, they used a whole shitload of math equations. I mean, it took me about 6 weeks to get through the 3-page article. But once I did, it was worth it. Incredible amount of information. And what they came up with was this, that the barrier to reflux was actually part the crura and part the LES. And in fact, if you look at their diagram, which they built on this high-resolution CT scanning and math equations, it looks very similar to what Allison described. That again, the crura are acting sort of like the puborectalis. This is Ravi's article that Peter already went over with you that also looked at this using very fancy high-definition cross-sectional imaging on a fresh cadaver, as well as 3D reconstruction of that area. And again, he saw that there were two nooses, a pair of nooses. Peter really talked about one, which you saw this, that the circular muscle layer of the distal esophagus kind of comes around at the angle of His to form those sling fibers. But additionally, the crura of the diaphragm are providing that other noose, that other barrier to reflux, and it's predominantly the right crus. That's the major component here. This is another publication by Ravi Mittal, same year, where now he factored in 3D high-resolution manometry to sort of tease out the pressure in that area to again confirm at the end of the day that the barrier was made up of both the LES and the crural diaphragm. And again, the right crura seeming to be more predominant here. So that's all well and good, right? But that doesn't prove anything. Yes, maybe the crura are part of this, but maybe they don't go bad. Maybe Peter's right, it's just all about the LES deteriorating. And the crura never change at all. So it begs the question, are the crura normal? Are the crura normal in GERD patients? Well, an interesting study here by Souza, who looked at this very question. He took 20 patients with reflux. They had mild grades of esophagitis. They had small little Hhiatal hernias for half the group, no hernias in the other group. And he did high-resolution manometry and endoscopic ultrasound. Now, why on earth would he do endoscopic ultrasound? Well, the reason he did endoscopic ultrasound is because he wanted to measure the thickness of the right crura. Because again, following along here, that seems to be the culprit in reflux. So they did high-resolution manometry, endoscopic ultrasound, measured the right crural thickness, as well as the crural contribution to the barrier. And at the end of the day, what they found should be no surprise. The crural contribution was lower in GERD patients. And lo and behold, the right crura were thinner in GERD patients. Which again is no surprise for the surgeons in the audience, because when we're in there fixing somebody with bad reflux, the one crura that seems to be thin and falling apart is that right crura. So again, there seems to be a functional deficiency of the crura in GERD patients. But that's all well and good, but what we really need is a proof of concept model. Right? We need to take somebody or something that's normal, and we need to suddenly make them abnormal and see what happens. So in other words, we need to knock out the crura and see if that matters. So again, having no friends, I was up late at night thinking about this. I'm like, how on earth could I put together some sort of proof of concept model to prove to all of you that the crura are important, and if you lose your crura, you're going to have reflux? Well, I thought to myself, I've got 3 cats. I've got 3 cats. The kids aren't going to miss the cats. They don't even play with the goddamn cats. I'll go down late at night. I'll take the cats and I'll cut their crura. Yeah, I'll lacerate the crura of the cat and see what happens. Well, as I said earlier, history is important. And unbeknownst to me, somebody already did this study. Ravi Mittal beat me to the punch by about 2 decades. Ravi took his, now the difference here, and I think Ravi is in the audience, but Ravi at the time, believe it or not, had 4 cats. So he was already ahead of me as far as how this went, but he had 4 cats. And so he did esophageal manometry and 24-hour pH testing on these cats before and after he went in and cut their crura. Phenomenal. Well, lo and behold, you cut the crura of a cat and the EGJ pressure decreases. And then lo and behold, and I didn't know this, but did you know cats have reflux? Well, you cut their crura and cats have more reflux. So again, demonstrating conclusively to me that crural dysfunction increases reflux. And so if you'd asked me 10 years ago, what's the role of the crura? I would have stood up here and I would have said, it's involved with breathing, and it functions as a door jamb, meaning it holds that hole open so the esophagus can get through it to meet up with the stomach, right? Yeah, sounds reasonable. Interesting study out of Europe where they were doing ventral hernia repairs on patients. Patients didn't have reflux or anything like that, they just had a ventral hernia. So they were doing them open, so while they had the patients open, the one surgeon said to the other surgeon, hey, why don't we stick EMG electrodes into the crura of the diaphragm? Yeah, that sounds like a great study. Let's do it. Well, actually, let's take it one step further and let's do an endoscopy and let's blow up a balloon in the esophagus. Wow, that sounds like a fantastic idea. Let's put EMG electrodes into the crura of the diaphragm. We'll blow up a balloon, simulating a food bolus in your esophagus, and see what happens to the crura. Well, lo and behold, what happens to the crura is it relaxes. It relaxes to allow that food bolus into the stomach. Well, they took it one step further and they blew up a bigger balloon in the stomach. Bigger balloon in the stomach to simulate a full meal. And you know what happens when you have a full meal? the crura of the diaphragm contract to prevent reflux. There's some sort of neuromodulation of the crura, which again, nobody ever talks about, but it's been published. There's actual vagal, sensory, and motor neurons that functionally innervate the crura. And believe it or not, those vagal and motor neurons are the same ones that innervate the distal esophagus, i.e. LES, and the crura. So I would propose to Peter that maybe these TLESR thingies be renamed to TCDRs, transient crural diaphragmatic relaxations. That may be what's going on here. Why is any of this important? Because if we're going to fix reflux, we've got to realize this. Any anti-reflux procedure, by definition, has two parts now. Because the barrier to reflux is both the LES and the integrity of the crura. So part one has always been to fix the hiatal hernia. You've got to restore the integrity of the crura. And then part two is to fix the LES. And nowadays we have a whole boatload of things to fix the LES, a plethora. And so the question for me became, well, yes, we've got to fix the hernia, but it's the age-old question. Does size matter? Well, Peter, I'm happy to report that the answer to that is no. Size does not matter. And what do I mean by that? Big ones need to be fixed. I will tell you right now, small ones need to be fixed. And I will go one step further and tell you that absent ones need to be fixed. Now, before you think I've gone completely batshit crazy, let me explain. I will argue that the crura are defective in all GERD patients, even if you can't identify a hiatal hernia. Because I will argue that a hiatal hernia is actually a late sign of crural dysfunction or deterioration. You just don't wake up one day with a 5-centimeter hernia and normal crura. The hiatal hernia forms because your crura deteriorate. It's underlying crural dysfunction that's leading to these hiatal hernias. Very interesting study by Peter himself, John Bandolfino, and others. And I don't think this was the intention of their publication. But they had 31 GERD patients. Now what's interesting here is none of these patients had a hiatal hernia. They were all pH positive, they were all symptomatic reflux patients, but none of them had a hiatal hernia. They had a control group. They did 3D high-resolution manometry to separate the lower esophageal sphincter and the crural contribution to that barrier, to tease out how much the crura are contributing to the barrier in patients without a hiatal hernia. And you want to know something? The crural contribution is lower in patients with reflux even when they don't have a hiatal hernia. They correlated this as the crura deteriorated. That was associated with increased acid exposure for both the LES and the crura of the diaphragm. And so again, at the end of the day, that both the LES and the crura contribute to the barrier. And in fact, the crura are defective in GERD patients even if you can't identify a hiatal hernia, which to me implies there's a structural defect in the crural muscle fibers. Now this is a fascinating study out of Italy, and this could only be done in Italy for obvious reasons here in a minute. They went in while they were doing a hiatal hernia repair and a Nissen fundoplication, and they decided to take a chunk of muscle out of the crura. They then had it analyzed under transmission electron microscopy to see if there was any abnormalities in the crural muscle fiber itself. They had 33 patients with reflux. They all had small little hiatal hernias. They excluded anybody with big hernias or redos. They were all pH positive. But where it gets weird and where it can only be done in Italy is they had a control group. They had a group of patients that were coming in with symptomatic cholelithiasis. The surgeon went in there, took the gallbladder out, made a right-hand turn, went straight for the crura, and took a chunk of muscle out. Apparently you don't need an IRB. At the end of the day, what they found was this: 94% of them had muscular abnormalities of the crura. And 75% of the time, these were severe abnormalities, degeneration of the myofibers themselves. I know you're all dying to know. There were no problems in the lap chole patients. Now, to prove my theory, to validate it that you can do anything you want in Italy, the study was repeated in 2014 in a bigger set of patients, now 51 patients with reflux and 30 patients that didn't have reflux. And lo and behold, the results were the same. There was abnormalities in the crural muscle fiber. And to me, this sort of implies that there's some sort of connective tissue disorder going on here. We don't talk about it, but there's some underlying issue. This is a fascinating study where they took biopsies from around the hiatus in GERD patients. They also had a control group, this time it was cadavers, and they looked at the total amount of collagen, as well as type 1 collagen and type 3 collagen in the Hhiatal area. And what they found was actually quite surprising. In patients with hiatal hernias, the collagen content, total type 1 and type 3, was 60% lower compared to patients that didn't have reflux. So to me, this implies that this is a genetic disease, reflux. Fascinating study that looked at that very question, whether or not there's any genetic relationship in reflux. They did genetic analysis on 4 separate patient cohorts that had familial clustering of reflux. It amounted to 36 different families with over 800 patients, as well as a control group. They were pediatric as well as adult. And they also did additional protein analysis. And what they found was that the gene was for collagen type 3 on chromosome number 2, pretty convincingly that was the disorder in these patients, that this was a genetic connective tissue disease. And so why does any of this matter? Like I said, there's got to be a point to all this. Well, the point to all this, you've got to ask your question, why does anti-reflux procedures fail? Well, the reason they fail is because of recurrence of the hiatal hernias. This is an interesting publication, and there's actually quite a few of these. Sumit Mittal actually has one himself, where they looked at about 300 patients that had recurrent reflux after anti-reflux surgery and asked the question, why? Is the crura intact in these patients? They broke it down into type of reherniations, whether it was just pure stomach herniating through the wrap, or whether it was a paraesophageal hernia, or the more common thing they find was this, where the whole wrap and stomach herniated up into the chest. And you want to know something? 86% of the time, the reason the patient had the reflux back was because of recurrence of the hiatal hernia. So I've run over my time, so I just want to summarize kind of everything that I told you. And it's right here. Because you can clearly see, now that I've taught you everything that I know, is that the GERD barrier is both the crura and the LES. The crura, I will tell you, are defective in all GERD patients. Hiatal hernia is a late sign. Anti-reflux surgery is 2 surgeries in one, a crural repair and an LES repair. I think there is something to this, that this may be a connective tissue genetic disease. Because I can tell you, failure of this surgery is predominantly due to failure of the hernias. This is where we need to focus our research. If we can decrease the recurrence rates, I think we will make a big difference here. Anyway, that's all I got. Thank you very much.